Oluwafemi Akande. I'm presenting a paper titled Implication of Urbanization on Housing Quality and Health Towards a Redirection in Housing Provision in Nigeria. The presentation overview is as follows. The study background, the literature outcome, the conceptual framework, the aim and the study area, the methods and material, the results, the key findings, the study limitations, and the conclusion. Nigeria is a lower middle income country and Africa's most populous country with approximate of 200 million people. The poorest socioeconomic groups in Nigeria is about 50.2% of its urban populace. This populace, they lack adequate supply of urban housing. Since the 1960s, when Nigerian got our independence, Nigerian cities have had a growing deficit in housing provision. This became worse due to the nation's urbanization challenges. Currently, Nigerian housing deficit was estimated to be between 12 to 16 million housing units in order to cater for its growing populace. Natural ventilation and indoor air quality in millions of the houses already provided are often poor, and they result in the prevalence of airborne disease transmission. Now, the growing urbanization has led to millions of substandard, poorly designed, and crowded houses, as can be seen on the screen. This results in ill health of most of the occupants. I will discuss the literature review under 4 key areas. Number 1, architecture and health. 2, healthy housing. 3, housing quality. And 4, housing indoor environment. Under the architecture and health, Arundel et al. Posited that ventilation still remains a key design strategy to lessen the spread of infectious disease in the indoors. This is what is most lacking in most of the houses currently provided in Nigeria. Under the healthy housing, fully loved and fully loved stated that deficient and worsening housing condition can trigger a range of diseases. This may include lung diseases, neurological disorder, mental and behavioral dysfunction. Then that takes me to housing quality. The World Health Organization identified indoor air quality as the 8th most important risk factor, and that is responsible for about 2.7% of the global burden of disease. Under the housing environment, Grudens et al. Identified and reported indoor characteristics such as temperature, relative humidity, air velocity, ventilation, accumulation of biological pollutants, and infection potentials to seriously deteriorate indoor environment. From this literature review, the gap identified and the deficiency identified in the literature review has led to the conceptual framework. The conceptual framework described the implication of urban housing and health in Nigeria. 5 major factors have been identified under this conceptual framework. We have the housing drivers, then followed by the housing deficit, then the housing delivery and deficiency, and then we have the housing dwellers' demand. These major factors are the major factors that are considered in the study. The aim and objective of the study is stated on the screen. The aim is to assess the indoor air quality and health risk associated with urban housing provision in developing countries like Nigeria. 2 objectives are considered in this paper. Number 1, to determine the correlation between the health symptoms and building parameters and air quality parameters. And 2, to improve the health quality of housing provision in an emerging economy like Nigeria. The study area is displayed on the screen as follows. The study area is at Bauchi Metropolis in Nigeria. Bauchi State is one of the 36 states of the Nigerian Federation. It covers a land area of 3,687 square kilometers, with a population of 493,810. Bauchi Metropolis consists of 8 administrative wards. Each ward consists of 43,654 households distributed in the low, medium, and high density neighborhood, as can be shown. This particular study was taken from one of the 8 wards in Bauchi, which is called the Yewa ward, and this is what the housing environment looks like in that ward. The method and material that was used for this study is divided into 3 basic areas. Number 1, we made use of health questionnaire, which included the demographic, the age, the respondent characteristics, their reported health issues and symptoms, and how the buildings are operated. Number 2, we also carried out an overnight monitoring of CO2, temperature, PM 2.5, which is particulate matter of 2.5, and particulate matter of the size of 10, were conducted in about 115 houses separated into 8 neighborhoods. Air quality parameters were measured using air node sensor, or otherwise called air visual, produced in the USA. A building audit was also carried out, which recorded the room and the window types, the sizes, the location and orientation of the building, and some other aspects of the operation of the building, such as cooking fuel sources. This current slide presents the results and the findings of the study so far. The majority of the respondents in this study, which is about 47.6% of them, they had a monthly income of $50, which is just about $1.25 per day for a household with an average size of 4 family members. About 50% of the household use kerosene, firewood, charcoal, and combination of the 3 for cooking purposes in the building. The mean concentration, that is the PM 2.5 and PM 10 that we found in the study, range from 10 micrometer cube to 231 micrometer cube. Now the 2.5, the particulate matter of the size 2.5 was recorded, the average of the concentration was recorded for 63 micrometer cube, while the PM10 was recorded for 220 micrometer cube. Further results shows that the majority of the household were exposed to higher than the WHO guideline value of 25 and 50 micrometer cube. As already indicated, what we got quite much a higher value than what the WHO guideline benchmark was. The mean concentration of the CO2, however, was 584 parts per million, which indicated that the ventilation was adequate, having a range of 403 parts per million to 2,201 parts per million. The mean temperature found in the building was quite slightly higher, which recorded 28.9 degrees centigrade. This is slightly exceeded the ASHRAE recommended value that's supposed to be between 21 to 26 degrees centigrade. The relative humidity was quite within the recommended value of ASHRAE, which is found to be 40.7%. Further findings here shows that while the findings in the study suggest that the building tends to be well ventilated with average CO2 levels in the bedroom rarely surpassing 1,000 parts per million, the reason for this could be as a result of multiple interacting factors, such as the way the occupants operated their buildings. Many houses are also within a secured fence, as can be seen on the screen, and around a courtyard. So this allows the households to be able to leave their windows open for long hours, both night and day, therefore reducing the effect of poor ventilation system in the building. Other key findings that were found, as shown on the screen, shows a weak positive correlation that was found between PM2.5 and PM10 and CO2 and the main building orientation. This means that the building orientation and the indoor air quality and the indoor CO2 emissions are not significantly correlated. The building characteristics were cross-tabulated with the incidence of the reported disease so that we can explore the association between them. What we found was that the main building orientation showed significant association with the following illnesses: incidence of measles, meningitis, and tuberculosis. We also found out that the building floor materials are significantly associated with meningitis, measles, and influenza. Their odd ratio are less than 1. This implies that as the floor material improves from earth to wood and cement, and then it improves to a better floor material to rock, the odd of incidence of the three elements were significantly reduced. Logistic regression analysis of the disease along with the indoor air quality indicated that PM10 shows significant relationship with chickenpox and influenza, as can be seen on the screen, while PM2.5 shows significant relationship to influenza. This study is not without some limitations. The first limitation here in this study is the methodological limitation. Again, following the sample size was small to detect a strong association between the variables that were investigated. Indoor air quality and CO2 that was monitored between 8 to 12 hours, in contrast to 24 hours recommended by WHO. In this study, we also have a challenge of 24 hours continuous electricity supply, which led to the use of alternative source of energy such as power banks and generator to power the monitoring equipment as shown on the screen. This limits the number of hours the equipment can function, as it was not designed to work on alternative source of energy. The conclusion of this paper is that the study demonstrates association between certain building characteristics such as building orientation, the wall and the floor areas, and the housing type as potential risk in naturally ventilated residential building for certain diseases such as meningitis, measles, chickenpox, and influenza. This study calls for a redirection in quality housing provision in Nigeria rather than quantity in provision. This should be occupant centered with strategy to reduce the indoor particulate matter. This particulate matter combines to deteriorate the indoor environment and they trigger susceptibility to infectious diseases. A large-scale intervention study will be required with large sample size so that we can also have continuous measurement of indoor particulate matter and CO2 emission. This will be essential to capture the full range of air quality measurements and the association with occupant health outcome over time and space. Thank you for listening.